Thank you for taking the time this evening to join us for a Harley Academy webinar. Tonight is really the first in a series of webinars we're going to be doing, and it also represents a bit of a kind of new direction for Harley Academy, where we're going to be focusing much more on the research, the evidence, and really the science that underpins a lot of what we do. I think our industry moves very fast. The way in which we think about injecting in particular is changing every year. You may have noticed also trends happening across the sector, particularly in the UK. I think sometimes we get a bit conscious of fillers. We did a lot of fillers 2 years ago. Patients had a lot of treatments. I think this year a lot of people look for regenerative treatments. And so the industry moves quickly. And what we want to be doing is helping our audience, helping our trainees stay on top of the very latest in what's happening on the research front, on the academic front, and also give you some timeless principles for what you can use in your practice. One thing does not change over time, and that's anatomy. Maybe our interpretation or our understanding of it does, but if you have a firm grasp on anatomy, then everything that emerges within our field, whether that's new devices, new technologies, new injectables, it will be one of the most fundamental basic sciences that you can have. And so I'm very happy to be joining our webinar this evening. We have Professor Sebastian Cotofana. For those who don't know him, he is a leading anatomist across the world, and he is joining us this evening to give us an in-depth view on some real core evidence-based principles for injecting. This is something that we've been speaking about over the last year and will become an increasing part of our curriculum. But what I really want to do is hear from Sebastian himself on some fundamental principles that apply across what we do, based on the science and the research that he's intimately involved in. So without further ado, handing over to you, Sebastian.
Well, Tristan, thank you very much for having me for this webinar tonight. I mean, for you guys, for me, it's 1 p.m. in the afternoon, but my internal clock, I think, is somewhere in the midnight or so. I don't know. I don't know where my internal clock is, but I can tell you it's not here. And I'm very happy to be joining you on this one, and also warm welcome to all of the Harley Academy members who are in here, and also of those of you who are all around the world. So the topic of this webinar, which will last 45 minutes, and you might say that short, yes, because the retention rate sometimes is a little bit different from the normal webinar. So we have it a 45-minute discussion, and I think when we speak about principles of aesthetic medicine, most of you might say, and maybe Tristan, he can confirm this throughout this webinar, is the fact that normally the principles that we have are the aesthetic desire of the patient and the budget of the patient. Or Tristan, based on clinical experience, these are normally the principles that we treat upon, right?
Yeah, exactly. I think we have to have something that gives us structure in our consultations, and often we are led by the patient, what the patient wants, and then ultimately interfacing that with what they can afford, and then all of a sudden we have an idea of what treatments we can do.
Yeah. So in other words, when a patient comes into your office and says, well, my concern is the nasolabial fold, and I have budget only for 1 or 2 syringes, I mean, there's already the framework set of what you can do and what will you do for this patient, right?
Usually, yeah. I mean, that would give me about 2 or 3 different things that I would be able to deliver for that patient. And it's a framework that's based on the commercials. It's based on the patient's main primary concern that they present with.
Yeah. And I think here's the important aspect that we need to consider for this one, and this will delve into some of the research aspects that we're currently planning in collaboration with Harley Academy, and in certain aspects that we're doing together in terms of validation and understanding is, and based on this, I have a very important question for Tristan. Tristan, when you treat a patient and you think the outcome is amazing, let's say treating the nasolabial fold, but the patient thinks it looks worse than before, what is the outcome of that treatment? who evaluates the treatment? Who determines if the treatment was successful? Who does, I mean, based on what?
This is, I think, this is an interesting point we're discussing, which is around the ownership of that treatment. And the right answer, I believe, is the patient. It's always ultimately the patient's subject. The idea with what we're doing is we're working with psychological subjective concerns, and our goal is to improve those in a safe and effective way. And I think a lot of doctors or clinicians project their own wonderful ideas of what they want to achieve because they've learned something, or they've tried a new product, or because they've read a research paper, or because, and something like that. But I think, and then probably to your point, we lose touch of the actual job that we have, which is to address a patient's concern.
I think this is very important to understand. And here, I would like to mention this to the audience, that when we assess patients, either we as the injectors, or like Tristan, I mean, you assess the patient, and you assess the patient based on what you think the patient needs. Because I'm sure you can do assessment, even blinded assessment of a patient face, independent if you talk to the patient, yes or no. And I think if you show the pictures of that patient to a group of raters, maybe most of them will converge towards one aesthetic deficit that all of the injectors at some point would jump on, even without having talked to the patient, right?
Yeah, I think so too.
And yeah, but then this is what we project onto the patient. But then the patient might be totally different. Kind of like, well, yeah, I know I have deep nasolabial folds, but my primary concern is actually the chin or so. And then all of the aesthetic assessment was based only on nasolabial fold, but actually the treatment here was patient on the chin. And then if we would leave the patient out of the equation, we would even conduct the assessment based on scales. But who does that scale? The scale are designed for the injector. The scale is not designed for the patient. And this brings us to the dilemma of two aspects: patient assessment, which we do based on our knowledge, but the patient has only limited influence on this one, and then the outcome and who assesses the outcome. Is it us? Even for us, I mean, it's amazing outcome, amazing what we could do with one syringe, but the patient says, actually, I wanted this and not this. Can you dissolve this because I don't like it? Kind of like, and this is kind of like the thing what I feel in aesthetic medicine these days a little bit lacking, that we have everything made for us, but very few little things made for the patient. And but then the point is kind of like what truly matters. What matters is the patient, and what matters is also that we need to be aware of this. Because that's an issue that we cannot solve. None of us can solve it, because all of these tools were made for us, were not made for the patient. And it's not kind of like, oh, we're such bad injectors. No. This is the reality. There's nothing wrong on our side. It's just happened to be like this.
I think the way this has evolved in our field is because primary development has come from the research and development budgets from the manufacturers who speak to the professionals, and the professionals therefore have their tools, they have their frameworks, they have their training, but the actual work that needs to be done on the interface between the professional and the patient, and that process, the psychological aspects, the social aspects, and also the optimal consultation and treatment outcome aspects hasn't been done. And that is the next frontier, I think, in our field. The way I see that our field developing is, back when it started, we focused on products, and Restylane became FDA approved 1998 or something like this. Then we moved to technique, and we started thinking about cannulas and needles and 8-point lifts. Then we moved to a recent obsession, which is complications management, anatomy, ultrasound, Sebastian, all this kind of stuff. Everyone's obsessed. And then where are we going to go to next? I think we're going to go to the patient, and we're going to go to the psychological and the social components of what we do. That doesn't mean you're out of a job. We still need you.
Yeah. But honestly, my dear audience, I hope you heard what Tristan said, and I hope because this webinar is recording, it was so important. It was just like the aesthetic field in a nutshell. This is what Tristan just mentioned to you, and based on this, I hope you understand that there are a couple of things which is not our fault. The tools are just not there at this moment. And I think this is a thing that we need to be mindful, and especially also when we think about the assessment of beauty, what we think is beautiful might be different in what the patient perceives as beautiful. And in addition to this, it's also like what our perception of beauty is also influenced by many biases, like cognitive biases, like confirmation biases, and like the social and perception bias. All of these things influence our perception of beauty. In other words, even what we think is beautiful might not be the reality, which is interesting actually to consider that what we do is also full of flaws and full of mistakes, and we need always to take ourselves a little bit back, especially when we try sometimes to argue with the patient, like, oh no, this is beautiful, that's the latest trend. Maybe you should consider, is it really? Are you surely know what you're talking about? You know?
Yeah, but I think this is where we talk about risk as well. People talk about anatomical risk, vascular risk, injection complications. People don't talk about the complications that can arise when we mismanage a psychological concern. And that, I think, is currently we will look back and think we were doing things pretty badly because we often are projecting our own ideas. So
this is, again, this is really great, my dear audience. I hope you heard that. We are often projecting our own ideas onto the patient. I think this is also, again, so powerful to understand for the audience what it actually means, because sometimes we can be wrong. We know that we do never want to admit, and we're never wrong, always the others are wrong. I mean, this is how the human brain works, survival of the own individual, but it requires a lot of experience and also humble assessment of your own actions to say at some point that we might be wrong at some point as well. And I think if we factor this in what we do, then we're looking at this much more critical. And I think this is, again, Tristan, I mean, today you have amazing pearls for the audience. It's like, wow, honestly, I should just log off this webinar and you should just continue talking to them, because what you said is kind of like taking care of most of the aspects.
I think we're ready for some of your dissections and slides now.
Yeah, I would agree on this one. So again, this whole preface was to showcase that assessment and evaluation, so everything before and after the treatment, all of this is subjective and can have flaws, and we should just reflect on ourselves that, hey, that we might not be always perfect in our decision or choice. So these are the assessment and evaluation outcome. What happens in between? The treatment. How do we conduct the treatment? How we think about the treatment? And for this, we do have certain principles which are based on hard facts. And these I would like to show you in the following 20 minutes based on slides, which I will share right now with you. And after that, we will be coming back and continue our discussions on these topics. So for this, I will share my screen right now. And as I'm doing so, it's going to be this and share.
Perfect.
So one of the most important aspects is principle for procedures. Now you might, how can there be principles for something that we don't really can quantify? The answer is also principle based on the fact that if the patient would have unlimited budget, if the patient would allow you to inject whatever you feel is needed to improve the aesthetic appearance. So in other words, if you take out the patient and it would be just us in assessment and conducting the treatment and all of this, then there would be principles available, principles for aesthetic procedures. And these I would like to present to you. And important to note, I have nothing to disclose because the things that I'm presenting here to you are not influenced by any other aspects today that you can see here. So the first and most important aspect is just talking about basics of, and in basics of anatomy, yes, we know we have fat, we have muscle, but one most important aspect is to understand that these layers, and you can see this here, layers of the face. And these layers of the face, they are from the scalp, so from the hair-bearing area all the way through into the lower face. It's just layers all the way through. So, and we need to consider that respective area. We just need to consider that aspect. And if we start in a scalp, you can see the scalp is actually skin tissue upon a loose connective tissue and periosteum. So these 5 letters resemble the 5 layers that you can find in the scalp. And if you continue those, you can find them everywhere. For instance, you also have your midface. Orbicularis is connected to smatysma and to the smas. It's all one respective plane, even though some muscles do not really play fair in these aspects, but you can see this here. And if you go into the lower face, you can see this here again. You have the skin, you have the superficial fatty layer, and then you have the platysma. So everything is arranged in layers. And I think this is so crucial and important to understand that we have actually layers in the face. And from this, there are a couple of consequences that arise. First, if you treat one area, there can be effect on another area. So in other words, if you treat the upper face, it will influence the mid face. I think that's an important feature to understand. And you know this anyway, but I think it might be of relevance to understand this component. And if you understand this, then you also understand that with having layers, there is a 3-dimensional aspect of the face. So in other words, under the skin, there is fat, there is fascia, and there's deep fattiness, periosteum. So it gives you a sense of 3 dimensions. So in other words, you have the layers, and then you have 3 dimensions. All of this arises from the fact that the face is arranged as it is with the underlying anatomy. So now that we understand this, let me walk you through various aesthetic principles. And the first one is lateral face first. And the lateral face first principle refers to the fact that when you treat the face, it has been shown to be of advantage if you start in the lateral side of the face first before you move into the medial aspect. So in other words, targeting the zygomatic arch before you start the medial cheek, targeting the temple before you start to target the nasolabial folds, or targeting the lateral midface, the preauricular area, before you target the jawls and the marionette line. So in other words, just keeping more lateral in the beginning and then later on moving medially, this is what the first aesthetic principles mentioned, lateral face first. And I will walk you through now how we came up to this. We did a study in which we asked patients to smile. And then we looked in which area of the face do we have a greater mobility. Was it medial to line of ligaments or lateral to line of ligaments? And the line of ligaments is this white line here indicated in this image here. You can see this on the most right image. And here we found out that the majority of the mobility is in the medial face. I mean, it makes sense because there you have muscles of facial expression which move the skin. So it's totally normal kind of to understand that when there's muscles, there's movement. In lateral face, we do not have muscles of facial expression. There we have only muscles of mastication, whereas medially we do. So first of all, we found out medially you have much more active mobility. And then with another study, which you can see here, and in this study, we had an interesting study design. We asked patients to stand upright and lay down. And then we found out that the majority of the mobility happens in the lateral face. You can see here, +5, well, almost +6 cc's. You can see this in the most lateral aspect here. And it just shows that in the lateral face, you have more mobility, but this mobility is a passive mobility. So in other words, in the lateral face, you have a passive mobility, which you can influence, which is independent of your facial expression, whereas medially, you cannot really influence that, but it is predominantly influenced by your facial expression. So I think that's an important feature to understand between medial and lateral. And then there was a study years ago in 2019, and in 2019, what happened was, in this study design, we injected various injection points. I mean, to be precise, same injection points, but in a different sequence. On one side of the face, and I think this is the big strength of that study, is that on one side of the face, the injection sequence was lateral face injection points, and then later on it was medial face injection points. And the outcome was to measure how much volume was needed in the medial face to achieve a symmetric outcome. But the funny thing is, both sides of the face were injected medially. Only on one side, the lateral face was injected first, and then it would make sense that the volume that you inject medially is actually equal if there is no influence of the sequence of your injection technique. So the kind of like in terms of statistics, the H0 hypothesis is that there's no difference, because actually, why should there be a difference if you start on one side lateral face first, and on the other side medial face? I mean, it makes no real sense that there is a difference. But interesting enough, there was a difference. When we did the analysis, and you can see this here, we found out that you need a different amount of product to volumize the midface, depending on if you start lateral face first or medial face first. In other words, if you target the midface, you need more volume. If you target the lateral face first and then the midface, you need less volume in the midface. And less volume in a midface is something very important, because your patients do not have an infinite budget, first. Second, more product increases the risk of adverse events. And third, more product increases the risk of having a non-natural outcome, which like a pillow face or overfilled syndrome. So these are the things that you need to consider why it is of relevance to reduce the amount of filler that you inject into the face. And by injecting lateral face first, you need less volume to volumize the medial midface. I think that was a really interesting study that shows the difference. And everything starts with the understanding of anatomy, and starts also with the understanding of the line of ligaments, because as you can see in a caption under the slide, it says lateral line of ligaments. But for this, you need to know what the line of ligaments is, right? And I think this is also an important feature where anatomy can help you, and where anatomy can be a guide for your aesthetic outcomes. And now I want to move with you into the second aesthetic principle, which is the upper face first. Again, the premise is you have an infinite amount of product available, and you can treat any region that you consider necessary in the patient, independent of budgetary restraints, what we talked before, and aesthetic needs of the patient. So I think if you take these things out that we discussed previously with Tristan, then you focus on your aesthetic principle. And the second aesthetic principle is the upper face first. And the reason why we came up with this principle was the arrangement of the face, which is arranged in layers. I think I mentioned this to you before, but it's very important for you to understand that even before this aesthetic principle was formulated, people were injecting like this, because you find out empirically and based on your own clinical experience that if you inject along the zygomatic arch, you will have an improvement of the midface and of the lower face. I mean, that's clear, just how it is. And I think this understanding is so crucial. It's very crucial for us to understand, because it will direct our treatments. But at the end of the day, I still had to do a study on this. And this is the study. It says the clinical validation of the upper face first principle. And in this study, we did a very interesting study design, because unlike the previous study, which used an unlimited amount of product, but the outcome was a symmetric facial appearance. That was the previous study. In this study, the amount was fixed. So in other words, the amount that you could inject in the face was predetermined. And the only thing that varied was the aesthetic outcome. So this is a little bit of a different and more challenging result, because you make it depending on the aesthetic outcome, not on the amount that you will be injecting. And what we did in the study was that one side of the face was injected with the upper face first, then mid face and lower face. And then the other side of the face in the same patient was injected by the same injection points and via the same amount of product, and of course type of product. Everything was equal. The only difference was the other side of the face was injected lower face, mid face, upper face. So in other words, same injection points, same volume, same product, same treatment algorithm. The only thing that was different, one side of the face, upper, middle, lower face, the other side of the face, lower face, mid face, and upper face. And again, same amount of product. And here is kind of like the mid-facial volume when you rate it based on pictures by independent observers. And this is the baseline. Of course, the baseline, there was no difference. But immediately after the treatment, at day 0, kind of like the same day the treatment was performed, there was a statistically significant volume or improved volume in the upper face first algorithm. Now, I have to explain something here to the scale. The scale is here from 0 to 4. And 4 is worst and 0 is best. And the scale is no volume loss, 1 is mild, 2 is moderate, 3 is severe, and 4 is very severe. So in other words, the closer to 0, the better. And here you can see actually that immediately after injection, the upper face first algorithm scored better, even though the same amount of volume was injected. And later on, of course, the difference is not statistically significant different anymore, but there is a trend. And the reason why we're losing statistical significance is because the changes are so small. If the changes would be larger, we would see more difference. And if the sample size would be larger, we'll also see more difference. But there is a trend. There's a clear trend that you can see here. And this is when you measure the volume in the midface. Here, the measured volume in the midface, of course, is relying on the fact that the higher, here you can see on the y-axis with 3, the higher, the better. And look at this. Immediately after the treatment, upper face first algorithm, more volume, measured more volume. At day 30 and at day 90, so that means 3 months after, you can also still see that it has still more volume, the upper face first algorithm. Interestingly, but independent. If there's statistical significance or not, there is a trend. And it was the same amount of volume was injected, the same amount. But still we measure and capture differences. And when you ask kind of like the global aesthetic improvement scale, which side of the face was more improved? Well, then you can see highly statistical significant improvement for the upper face first algorithm versus the lower face algorithm. But the mind-blowing thing about this one, I'd like to bring it again to your attention, is that the same amount of volume was injected. So you understand that difference. And how to do this? Well, there's maybe the possibility of this publication, when you inject in the temple and then you improve the lower facial volume. You can see that here. So these are also possibilities that can help and how you can utilize the upper face first algorithm. And now we're coming to the third principle, which is deep first. And deep first means nothing else than you need to target the deep facial regions first. And when you think about targeting the deep regions first, I mean, it makes total sense because this is what you do anyway. But I want to explain to you why. The most important thing is to understand that we have 2 layers of fat, superficial and deep, and these 2 layers of fat are arranged in compartments. They can be compared like this, grapes and raisins. And when we lose volume, we just also lose the stability and the support. So in other words, the compartment will become empty as we age. And when they become empty, not only do we lose volume, which is visible that we lose volume, the face appears slimmer, but we also lose structural support. So in other words, when the volume is gone, everything becomes unstable. Best example, the tire of a bicycle. When there's no air in that tire, the tire is pretty unstable, almost that you drive on the rim, because the volumizing effect is gone. So not only do you lose volume, which you see that the tire is flat, but you also lose stability. So try to go around the corners with a flat tire with a bicycle. You might end up not liking that experience this much. But important to note, volume in a face represents two things, volumization and stabilization. We have two layers of fat, and now look at this video, how we can identify these various layers. So when here in this video, I'm reflecting the skin of the midface, and it shows in some areas thickness is very thin, as you can see here, and in other areas the thickness is just differently, especially in the infraorbital area, the skin is very thin. And then you can see superficial fat, you can see that area here, superficial fat, that I'm reflecting now. And when you expose that area, you suddenly start to see more important structures, like here the angular vein. That muscle is levator labii suprasellic venasi, and now we're moving into the tear trough, and look in the tear trough. There's no deep fat. It's just periosteum. There's no deep fat in a tear trough. And I think that's so crucial to understand that this area immediately lacks volume because there's no volume-giving structures. Laterally, you have zygomatic cutaneous ligament, and you have orbicularis retained ligament, and in between you have a space. That space is filled with fat. You were able to see that deep fat, and that space is the SUF. So in other words, there is an area of deep fat and there's an area of no deep fat. And the separation between those two areas is the angular vein, which corresponds to the vertical line passing through the medial limbus. And if you go deeper, well, then you have infraorbital nerve and infraorbital artery, which you can see here in this component. But the most important point is you need to understand in which areas of the face you have deep fat and which you don't have deep fat. And at tear trough, there you don't have deep fat. So this is an overview of the superficial fat compartments. You can see how they're arranged along the nasolabial fold, along the Marnette line, along the jowls. And these fat compartments are highly mobile. They move a lot. So now I want you to understand what it means when you apply your treatments. Will you apply the treatments into layer number 2, the superficial layer, which is highly mobile, which you can actually increase the heaviness and make nasolabial folds or jowls or Marnette even worse when you inject superficially? Or will you inject deep into layer number 4, into these fat compartments here? And when you inject into those fat compartments, what happens is then that you provide stability structure for everything that lies above. And above lies the superficial fat compartments. So in other words, if you know that there are superficial and deep fat compartments, you tend to target the deep ones, because when you volumize the deep ones, you restructure everything that is on top. You give, again, a structure and position to everything that is on top. And I think that's an important feature to consider, and why we should inject deep regions first, because we want to give these restructuring. But the other component is what happens if we inject a lot of product superficial. For this, you can see here we did a study on this one where we measured the mobility of the superficial versus the deep fat compartments, and you can see that only the superficial fat compartments move. This makes total sense medially because there we have muscular facial expression, and now you can understand that when you inject more product, not deep, but into the superficial fat compartments, you will affect the natural mobility. You will affect the natural mobility of those fat compartments because they need to move. Their premise is to normally move because this is what they do. And if you inject too much product, or even too much biostimulators medially, you will limit and restrict this natural mobility. And when you restrict this natural mobility, it will result in a non-natural facial experience and non-natural facial mimicking during various facial expression.
Sebastian, can I ask you a question whilst we're talking about this topic? One of
Sure.
the things we've had a few questions around is this hypothesis of volume loss, migration with the fat pads, deep and superficial. Do we have any studies or research to demonstrate? Because you've showed us with the kind of the deflation theory, right? With the deep fat. When it comes to the superficial fats, people will normally say, well, that when things slip down, it's because there's volume loss. Is there genuine volume loss? Is it migration? Is it gravity? Do we know?
So I'm trying to stick to those minor aspects here when it comes to the mobility of the fat compartments. But the reason why these fat compartments move 2 blocks down the road, so in other words, from the infraorbital area towards the nasolabial fold, why they move over there is multifactorial. The bone kind of like changes over time. The muscles in their resistance to gravity changes over time. The skin elasticity and firmness changes over time. And not only the fat itself kind of like deflates and contributes to loss of structure. So in other words, the reason why it goes down, it's multifactorial. But what I presented to you now, I just presented on a fat compartment. But if you understand that it's multifactorial, the question is always, okay, the bone recedes. What are you doing? Well, the answer to this is you take a high G' product and you inject deep in contact with the bone to mimic and to reshape the bony contour. And when you say, oh, what are we going to do about skin firmness? Well, then we might need to think about some biostimulators, because this also helps to reposition various aspects. And then we think about fat compartment, what you do, well, you need to use fillers for these ones, but which type of fillers? Because you cannot use high G' fillers with more than 1000 G' in a superficial area. No, you can't. You need to use a medium or low G' product with a very high coercivity, which allows to act upon the mobility and go and flow with the facial structures and not be like a rock. So if you understand that for each of these factors, there is a treatment modality, you need to understand that and why facial aesthetic procedures are multimodal. It's not only that we have only fillers at hand. No, we have many other tools in our hand, but to be able to use the tools accordingly, we need to understand what's going on. So in other words, when you're a mechanic, you need to know when to use a Torx or a screwdriver with a cross or a single slit screwdriver, or when you need to do like a Allen key. There are many different tools that we have, but we need to understand on what they are effective. And if we think about that, we want to volumize the bone with a biostimulator, then yes, there is an effect, but is it truly because of that? And that's a total different story. But I hope you understand that there's not only fatty deflation theory. There are many other things that come into play and that contribute to the same aesthetic appearance.
Sure. Thank you.
Sure. Actually, I finished with my slides because no, because the next slide is actually a thank you slide with this coming to an end of the presentation. So actually with this, we're coming to an end of this one. But in summary, I hope that everybody understands that if we take out the subjective assessment part and also the subjective evaluation part at the end, the in-between, it leaves the treatment algorithm. And the treatment algorithm is based and can be based on current aesthetic principles, which have been kind of like identified, only empirically in the beginning, and now we start to have a little bit of science behind them. But everything is just at the beginning. We're just in the beginning of this new medical field. If you think about how much research was done in other medical fields and how advanced they are. But here in aesthetics is more like, I'll try to do that, and then let's see where it goes, you know.
Yes, and I think this is what people need to appreciate is that if it feels like the landscape is shifting every few weeks, every few months, that's because it's moving so fast, and it will continue to surprise us, I think, year after year. And a lot of people, I think, what I just want to flag right now is there is a wealth of research you've done, anatomical and beyond, looking at every zone of the face, mid face, lower face, upper face. And what we're really excited to do is go through this journey with you, and we're going to be presenting what we're going to be calling the Anatomy Accelerator, which is another pair of webinars in May and June. And so what we're going to be able to do is go through a whistle-stop tour of every anatomical zone in the face. I'm really excited about this, and give you the latest evidence base for those injections as of the state of the research in 2024. And that's thousands and thousands of pounds or dollars worth of value that we're going to be giving away at a very good price of £150 for the pair of webinars, £149. So if anybody's interested in that, we're going to share a link and everyone can sign up to join us. That's going to be in May and in June. I'll just give you the dates now, 22nd of May and 5th of June. But really excited to learn more from you, Sebastian. I think what you're doing in the industry is fantastic. I think that the drive that you are bringing to our field and the paradigm shifts that we create from some of your work is what drew me to your work in the first place. And I want to thank you for that and acknowledge you for that.
And there's the link. I can see the link in the chat, which is great. There is the program. You can see that in the chat right away, posted for all of us.
So that will be next time we meet, which will be in May the 22nd, for more specifics on injection anatomy as we go through the face zone by zone. So I hope everyone has enjoyed that this evening. It's been great to spend our time together, and we're always here if you want to get in touch, send us questions, comments. Otherwise, we will see you next time.
Absolutely. Looking forward to this. And guys, if you can rewatch and re-listen to this webinar, because Tristan had some really very important pearls on this topic.
Thank you. All right. Good night. Thank you. Bye.
Bye, guys.